And now, it's Boomer Life, lifestyle discussion designed to make your life more engaging, meaningful, and complete. Celebrating the baby boomer generation, this is Boomer Life on CIL 650.
Well, good morning and welcome to Boomer Life here on CIL 650. Sterling Fox with you, joined in studio from Falls Creek Healthcare Center by Vancouver gynecologist Dr. Roy Jackson. We're going to talk about women's health on the program. Good morning, Dr. Jackson.
Good morning, Sterling. Great to be here today.
Well, I tell you, you're familiar to many CIL 650 listeners, Roy, because back a few years ago, you were the host of a program called Empowering Women right here on the airwaves of CIL. So welcome back.
Thank you very much. It's great to be back. Thank you.
So how was that show experience for you, stepping into my territory and on the radio? How was it? Was it fun?
Oh, it was fun to do it. I love to interview the various guests that we had, and hopefully the audience and the listeners benefited.
Tell us a little bit about what it is you do, because, you know, an OBGYN is what they used to call you in the old school point of reference, obstetrician and gynecologist. And yet when push comes to shove, if you were to ask most, particularly men, what a gynecologist does, we'd all probably go, well, he's the guy who delivers the babies.
Yes.
And that's not wrong. It's just incomplete, isn't it?
That's right. That's right. So that's a good question, Sterling, and I think it's a good chance for me to explain to the listeners what exactly an OBGYN does.
I'd appreciate that.
I mean, for me, my life and my job is very diverse. I spent this morning actually delivering a baby and doing a cesarean section. So most of the births that I get involved with are complicated ones where I'm either doing a cesarean section or a forceps-assisted delivery or a vacuum-assisted delivery. So that's the obstetrical side. Of what my job involves. On the gynecological side, it's taking care of women who have problems that are non-pregnant related problems, whether it's be a woman who has heavy periods, a woman who has problems with bladder control, or a woman who suffers from a condition called pelvic organ prolapse. So our job is varied, and we encompass all aspects of women's health.
Now, you are, among other things, you're a busy guy. In addition to being one of the staff people and director of gynecological services at Falls Creek Healthcare, Dr. Jackson, friends, is also on the staff of Peace Arch Hospital in White Rock and Delta Hospital, and also is medical director of Southern Health Center, which is a new facility in downtown White Rock. Tell us a little bit about that place.
Yes, thanks very much. Well, I've worked at Falls Creek since the inception of Falls Creek, which was about 12 or 13 years ago.
Exactly.
So I've been part of that organization for this time, and it's been fantastic to be part of that. In addition to that, in downtown White Rock, as you said, we've had now almost for 10 years, so it's not such a new organization, Southern Health Center, which is a multidisciplinary specialty clinic where we see patients. We don't do any surgeries on site there. We don't do any further procedures, but we primarily consult with patients who then go on to have their surgery either at Peace Arch Hospital in White Rock, Delta Hospital in Ladner, or they go to Falls Creek Surgical Center for their surgery.
I see. Now, talk to us a little bit. It's an interesting perspective that I'm glad you're able to show about Falls Creek Healthcare. We've had quite a number of distinguished staff colleagues of yours on Boomer Life, but you've been with Falls Creek Healthcare Center right back to the very, very early days. So you've seen it transform from one man's idea to a practical, living, breathing reality, and it's quite a force now in Vancouver.
Absolutely, and I think from the outset, and to the present time where Falls Creek exists as a large organization today, I think it's always given, the people of BC, and in fact, a lot of our patients are coming from outside of the province as well. I see patients coming from Alberta. It gives patients a choice, and I think in today's age, I think people and women deserve a choice. They deserve a choice in the kind of healthcare they get, and for me as a gynecologist, obstetrician, no matter whether I'm working in White Rock, no matter whether I'm working at Peace Arch Hospital or Falls Creek, the quality of care that I'm going to aim to achieve is going to be the best possible care. And it's just a question of the actual facility, and Falls Creek offers patients a choice generally who don't want to wait in line. They have an option now to go to Falls Creek.
In doing a little read-up about you, and it does take a while, you're certainly a well-recorded individual. Dr. Jackson, it says, among other things, you've studied and practiced cosmetic gynecology. What's that?
So approximately about 10 years ago, in fact, almost at the same time that Falls Creek was setting up, I came across a well-known gynecologist in the United States, Dr. David Matlock, and I was fortunate to spend some time working with Dr. Matlock in the United States about 12 years ago, and he initiated some procedures that I went and spent time training with him and brought those procedures back to Canada to offer them to women in BC and offer them to women in Vancouver,
Okay.
which is what I do at Falls Creek.
Okay, and what sort of procedures would they be? Would we recognize them by name in many cases?
And generally, the cosmetic procedures that Dr. Matlock started doing, that I've followed on for the last 10 or 12 years now, really are in the new evolving realm of cosmetic gynecology, where women who are generally not satisfied with the way their appearance is in the vaginal area, they don't like the appearance of their labia, they have an opportunity now, if they wish, just like any other cosmetic surgery,
Okay.
to improve and enhance the appearance of the vaginal area. And in terms of the other procedure that Dr. Matlock pioneered and now brought up to Canada, and that's the procedure of vaginal tightening and vaginal rejuvenation, which applies to women who generally feel that sexual function is not as pleasurable as it was, and we have an ability now to offer them something to enhance that.
So, referring to the pleasurable quotient in sexual activity, I assume you're talking about childbirth, or after childbirth, there's not the same sizzle, if you don't mind my non-medical reference there. And so that's why they would come to you for that cosmetic adjustment, perhaps, or certainly to discuss it with you.
Correct. And I think you hit on the word there, sizzle. And I think that at the end of the day, it takes a lot for that sizzle to continue. And we just play a small part in maintaining the sizzle. I always say to my patients that, no matter what the vaginal area might look or feel like, if there's some other problems going on in their life, such as credit card problems, financial problems,
Sure, of
or
course.
other problems, having a new improved vagina is not necessarily going to fix everything. So by no means is it the panacea, but we offer these patients something in addition to really a multi-disciplinary approach to try and help them with their health care.
You're such a busy guy. Now, you talked about just a few hours ago delivering a somewhat complicated arrival of a little person in White Rock. Aside from the obstetrical assignments you take on, and you do the more difficult ones, what does the bulk of your gynecological work keep you busy doing most?
Yes, and I mean, this morning the baby that I delivered happened to be a breech baby, so that's, as you say, a little bit more of the complicated births that I get involved with. On the gynecological side, in other words, those women that come and see me that are not pregnant,
right,
the areas that I focus on a lot is one area I see a lot of is women in their 40s or 50s who have abnormal periods, abnormal menstrual bleeding,
right,
and that could be from a host of causes. Obviously, one thing you want to rule out is that it's not a cause caused by uterine cancer.
Right.
Once we've ruled out uterine cancer, which can be a common cause, we need to look at things like fibroids that could be causing a woman to suffer with heavy periods. And really, the treatments for this have changed dramatically over the years. Probably 15 years ago, most women in their 40s or 50s who suffered with heavy periods, they would get a hysterectomy.
Right.
And in fact, hysterectomies was one of the most common procedures in North America. At one stage in the US, they were doing about 600,000 hysterectomies a year. And in Canada, 10% of the population, we'd be doing about 60,000 hysterectomies a year.
And that's the removal of the uterus, correct?
Correct. And now with more innovative therapies, a lot of which we offer at Falls Creek, we're able to offer women an alternative to a hysterectomy. And this is really the expansion of innovation in women's health care. An example of this innovation when it comes to fibroid care, we now have good new medical management for fibroids, which includes taking a medication called Fibristol or ulipristal acetate, which helps women with fibroids.
Okay.
When it comes to women who suffer with heavy periods, we have the procedure of endometrial ablation, which we offer at Falls Creek as well. So really, for a woman who suffers with heavy periods who doesn't have cancer, we have a whole host of alternatives available now.
What are fibroids?
Fibroids are usually benign growths of the uterine muscle, and it can one of the common problems that it causes is a woman to have heavy periods. She might have some associated tiredness, lethargy, weakness, and anemia as a result of that.
Was the popularity of the hysterectomy simply because it was so easy? You went in, you removed the uterus, and took away so many problems and the potential for so many more? Was that why it was so popular?
Well, I think the reason it was popular is because women were suffering with their periods, and there was really limited alternatives, 15, 20 years ago, until we had the evolution of some of these newer technologies.
Right.
So I think that's led to that change.
Okay.
But I think what is important, which is really rewarding as a physician to be in women's healthcare, is that I think women are very good consumers of healthcare, and they're very discerning consumers of healthcare,
Right.
and they want to be empowered. And that is really what led to our previous radio show, is that I think women deserve and are entitled to be empowered with the knowledge and education about what's going on with their body and their healthcare. So again, just like I said to you earlier, I'm a big proponent of women having the choice in terms of where they want to receive their healthcare.
Yep.
And that's why I admire organizations like Falls Creek for allowing women to have a choice. I think as a healthcare provider working in the women's healthcare space, I see myself as an advocate that I can advocate for women to be entitled to get quality healthcare education. And again, kudos to the radio show for putting something on this like this, because it's an opportunity for women to be empowered with knowledge and education. And I believe that if women are empowered with knowledge and education, they are going to do better in terms of their healthcare.
And you've been in business as a doctor practicing since before the onset of the internet. And so you've grown up in your practice alongside the internet. So your assertion that women are discriminating consumers and really like to be informed consumers, hasn't the internet just been a godsend for so many Canadian women?
Really, well, Sterling, the way you say that, it makes me sound like I'm a dinosaur.
No, it's just come on so fast, Roy.
That I was invented before the internet. So I feel like I'm a bit of a dinosaur. But yes, it has come on fast. And I think personally, again, a lot of physicians refer to Dr. Google as something that's not good. And I personally believe that the internet is an adjunct to the delivery of quality information. And yes, there's internet information out there that might not be great quality, but to me, the internet provides another vehicle for women to tap into knowledge. So I'm a big supporter of quality information delivered through the internet.
Our guest this morning on Boomer Life is Dr. Roy Jackson from Falls Creek Healthcare Center. He is a gynecologist, and he is a vigorous individual with lots to say. I'm very much looking forward to the balance of this hour. So please stay with us. We'll be right back after this quick timeout.
Celebrating the baby boomer lifestyle. This is Boomer Life on CIL 650. We're back. This is Boomer Life on CIL 650.
Welcome back to the program. A pleasure to have Dr. Roy Jackson back in the studios of CIL 650. Loyal listeners may recall just a few short years ago when Dr. Jackson was the host of a program called Empowering Women Radio. And you've already made a couple of references to the fact that you were pretty enthusiastic about that because of the theme that it represents. Canadian women are they're active health consumers. They're keenly interested in their well-being and not at all averse to getting out and doing a lot of homework about themselves. And so as this is Boomer Life, so let's zoom in on boomers and talk about women, say 45 plus. And you've sort of been focusing the conversation in that direction anyway, Dr. Jackson. For women in their 40s and 50s and beyond, we're talking about some significant changes in anatomy in those years.
Right. And I think, for the patients that we see who are in that age category, for me as a gynecologist, seeing those women, one of the real necessities of my evaluation of a woman's problem comes with the need for imaging. And it comes with the need to access ultrasound and possibly MRI in making a decision as to what's wrong with some of these patients. And I think that the value of ultrasound in gynecology plays a key role. And again, one of the advantages for me as a gynecologist working at Falls Creek is that I have literally everything under one roof, whereby if I see a patient and I'm concerned as to if there's an abnormality of her uterus, the value of having an ultrasound literally right there within the same facility is a big plus for me.
Right, and plus you have this team this incredible team. We've met on this program. We've met some of your colleagues from Falls Creek. They're just a brilliant group of individuals, all of whom are under one roof. And if you run into a jam, you need some backup on a particular problem or perhaps a second opinion or whatever, they're right down the hall from you in many cases. How convenient is that?
Right, absolutely. And I think, it's well acknowledged now, and there's some really good data available, that the value of the multidisciplinary team has demonstrated significant enhancements and improvement in healthcare delivery.
Right.
And unfortunately, in some environments in BC and in the Lower Mainland, the healthcare is very fragmented, where a patient comes in to see a family doctor, she then waits a number of times to see a gynecologist.
Right.
She might then wait or have to travel somewhere for imaging. So I think ultimately, if we can create an environment where you've got the family doctor, you've got the gynecologist, you might have a nurse practitioner, you might have a urologist,
Yep.
you might have the radiologist, all working in one environment, it's really conducive to delivering quality care.
And one other thing, while we're on that same subject, is the quality of the surgical facilities at Falls Creek Healthcare Center. I've heard from fellow surgeons like yourself who use these facilities on a daily or weekly basis and who just sing their praises. They're able to collaborate. They can do interactive work with their colleagues around the world live while they're working on a patient. It's phenomenal. The technology at your fingertips down there.
Right. And it's yes, it is about the facility and the equipment, but more importantly, it's about the quality of the people that are working there.
Sure.
And the physicians that generally are part of the team, they are go-getters, they are the innovators, and we need more innovators in healthcare. We need more leaders, and we need more agents of change, because healthcare is moving so quickly.
Yes.
That we have to drive that innovation. And I think that for me, it's really exciting to be part of that kind of team.
I can well imagine it would be. Now, in order to see you, a gynecologist, a gynecological surgeon, does a person have to have a reference from their family doctor in order to get through the portal to see Dr. Jackson?
So essentially, if I'm seeing a patient who has been referred by a family doctor,
Okay.
that patient would be seeing me through the regular healthcare system in British Columbia, and yes, she would need a referral to see me.
Okay.
For those patients that are coming from out of province, or those patients that are coming to see me for a second opinion, where they've seen another gynecologist and they want to get a second opinion, Falls Creek does offer a second opinion service whereby I can see the patients there, or an out of province or an out of town offering as well.
Interesting stuff. Do many people, I mean, it's 2015, and we're supposed to be pretty up to speed on everything. Do many people say, I appreciate your thoughts and your time, doctor, but I think I'd like to have a second opinion, if you don't mind. Do you take offense when somebody says that?
Not at all. And in fact, a lot of my own patients that I'm seeing for a first opinion, so to speak, if there's some debate going on, I encourage them to get a second opinion.
Good for you.
And I think, again, really physicians in general need to understand that there's a value in a second opinion. Because, again, by pooling our brain power, surely we're going to enhance the quality of care being delivered.
Right.
So I encourage patients to seek out second opinions if that's what they feel that they need. And if I see a patient and I don't have that rapport with the patient, I think it's crucial that the patient has a rapport with their physician.
Yes.
So at that point, there should be a parting of the ways,
Mm-hmm.
and it should be amicable, and that we should, a patient just needs to have a good rapport with their specialist, just like I need to have a good rapport with the patient. Now, that brings me to the next question, and a lot of patients say, well, how can you assume that I'm going to find another doctor that's going to be willing to see me?
Right.
And I understand that that's some of the challenges of the
that's a
healthcare
fair
system.
comment, isn't it?
So
Yeah.
yes, on the other hand, I'm not being unrealistic, and
Right.
I'm saying that is a challenge for the healthcare system as well.
I'm curious, and this is just a curiosity question, but in my daughter, for example, in her early 30s, prefers a female doctor. You obviously flunked that physical many years ago. Have you had, over your years of practice as a gynecologist, have you lost patients from time to time who just get a little skittish and opt for a female colleague?
Absolutely, and I mean, I think that it's not a new discussion that the majority of these days that we see what we refer to as the feminization of medicine,
Right.
whereby more and more medical students and more doctors that are graduating are actually female.
True.
And less males. Certainly within the specialty of obstetrics and gynecology, we're seeing more and more females going into that specialty, and I can understand that. For me, as a gynecological surgeon, which is most of the work that I do,
Right.
where I'm seeing people requiring fairly complicated surgery, I think that, a male gynecologist, I've created a niche, and it's as a result of that niche that patients, I hope, and I'm assuming, are happy to see me,
Right.
because I offer them something in a specialized area.
Right. Well, and years of experience as well.
Hence the gray hairs.
Well,
Absolutely.
yes, okay. Now, I've had a couple of terms thrown at me during the break for your clarification, if you would, please. What are a laparoscopy and a hysteroscopy?
So, part of the assessment of a patient who's experiencing problems, we have the ability at a center like Falls Creek, where we can offer them a diagnostic hysteroscopy and a diagnostic laparoscopy.
So these would be people who've gone to their doctor, their family doctor, with some kind of internal problem that maybe the GP isn't even able to figure out, and he'll say, well, you need to go, I know who you need to see, and they send them off to you for diagnosis, right?
Right. And so, to start with, talking about diagnostic hysteroscopy, that really is a tool, it's a diagnostic procedure where we have a scope that enables us to look inside the uterine cavity.
Okay.
So for a woman who's suffering with heavy periods or irregular heavy periods or postmenopausal bleeding, in other words, she's finished her normal cycles, but now, and she suddenly out of the blue develops some postmenopausal bleeding.
Right.
As I said to you earlier, we need to make sure that we're not dealing with a uterine cancer.
Sure.
And one of the gold standards, one of the ways to rule out uterine cancer is for us to look inside the uterine cavity. So it's a very simple diagnostic procedure using good equipment that enables a gynecologist to look inside the uterus and rule out cancer. So we offer that procedure through the hospital system, and we offer it through Falls Creek Surgical Center as well.
Okay.
Very similar concept to that is the procedure of diagnostic laparoscopy. Now, a diagnostic laparoscopy would be for a patient who is suffering with pain, pelvic pain or abdominal pain, where you don't know what the cause of the pain is.
But there's no bleeding attached to it
There might not
necessarily.
be, correct.
Okay.
There might not be any bleeding. She, let's say, has had an ultrasound. The ultrasound hasn't determined the cause of the pain or the
Okay.
cause of the problem, and you want to get a look inside her abdomen, inside her pelvis. So the ability to put a very fine scope. Some of these scopes, believe it or not, are no more than 3 or 4 millimeters in diameter. These scopes can go in through the belly button while the patient is asleep to enable us to assess what's happening in the abdomen and pelvis to try and come to a diagnosis as to what's causing the problem.
Certainly a minimally invasive approach now, isn't it? A tiny little hole for a little fiber optic camera cable to go down, right?
Exactly.
And so are these the two most common types of diagnostic work you do?
Certainly, and I mean, I do those on a regular basis. I mean, I'm doing several of those through the week, both in the hospital and at Falls Creek. We offer it as well.
Okay. Now, you also mentioned the term ultrasound a few times, and I can remember back to when the kids were coming along, we would go to the doctor's office and we would have the ultrasound, and you could see the child in the womb. And that's
Right.
the only exposure to ultrasound I've had in my whole life. So how does ultrasound factor into the work of a gynecologist or a gynecological surgeon?
And I think that, ultrasound really, in a way, is such a crucial modality when it comes to imaging for the benefit of a gynecologist and gynecological surgeon, in that we really rely on ultrasound to help us. And it is so much more valuable, to the point that it's actually more valuable than a CT scan.
Interesting.
And in fact, it's a lot safer than a CT scan because the patient is exposed to less radiation from ultrasound than she does get with a CT scan. So the value of ultrasound is huge for my practice, and I use it for a lot of non-pregnant conditions, gynecological problems,
Right.
where patients would get a pelvic ultrasound done through their pelvis. Sometimes, which is valuable as well, we might do what's called an endovaginal ultrasound, especially if you're looking at the uterine cavity or you're looking at the ovaries, to rule out any problems with the uterus or to rule out any problems with the ovaries. The patient might have an endovaginal ultrasound.
Now, if you could just bear with me for a couple of seconds, it's the educational component here, because you're talking now about diagnostic tools.
Right.
You're talking about ultrasounds. You've mentioned CT scans, and the other diagnostic tool that we're most aware of, that you've also mentioned a couple of times, is the MRI.
Right.
What's the difference between the results or what's the difference between the three? I find particularly the MRI and the CT scan to be, from a layman's perspective, almost the same thing. How do they differ?
Right. Well, again, I think that the imaging modality available and the use that it has varies from one specialty of medicine to the other.
Okay.
So for gynecology, as I said to you earlier, ultrasound is invaluable. The other valuable modality that we turn to is MRI, because it enables us to look at soft tissue problems. To give an example of what I'm referring to from a soft tissue point of view,
okay,
if we mentioned this earlier, and that is fibroids. One of the best modalities other than ultrasound to look at a fibroid would be the role that MRI plays at looking at fibroids.
So they would show up on an MRI?
They would show up on an MRI.
Okay.
Where are they located? One of the key things with fibroids is where is it located in the uterus?
Right.
It's a benign tumor of the uterus. Is it on the inside of the uterine cavity, what we refer to as a submucous fibroid? Is it in the wall of the uterine cavity, which is an intramural fibroid? Or is it on the outside of the uterine cavity, which would be regarded as a subserous fibroid? So really the location can easily be determined by ultrasound and also by MRI.
Does the location make a difference as to the degree of urgency for surgery or removal of these fibroids?
It makes a huge difference, because when we plan in the surgery, to see if a patient is a candidate or eligible for, say, a hysteroscopic procedure that we might do at Falls Creek,
okay,
you need to know where that fibroid is located. If the fibroid is submucous, I know that she could be eligible to have that done in an ambulatory surgical setting like Falls Creek Surgical Center. So the role of ultrasound and MRI in planning what's going to happen and trying to come to a diagnosis is crucial. Another condition in women's health and in gynecology where MRI plays a key role over and above what ultrasound does is to look for a condition, again, which causes pain and bleeding problems in women, a condition such as endometriosis or adenomyosis. These are non-cancerous conditions that we rely on MRI to help us determine what's causing the problem.
Okay. And the CT scan, by comparison to an MRI, isn't as effective at identifying soft tissue problems.
Correct.
Okay, so would the CT scan be better at bone issues then?
Yes, I mean, we still rely on a CT scan if you're looking at someone who might have an ovarian cyst or an ovarian mass.
Right.
So CT scan might help us there as well. But I think, from an educational point of view for our listener, a lot of patients who I see who might have an ultrasound done, she says, well, doctor, don't you think I need to have a CT scan? And I might say to you, no, I've got a lot of information from the ultrasound.
Right.
I don't think you need to jump into having a CT so quickly.
Okay, so why go there if you don't need to?
Exactly.
Interesting stuff. We need to take another quick break. This is flashing by just unbelievably rapidly. Our guest, gynecologist Dr. Roy Jackson from Falls Creek Healthcare Center. By the way, you can learn more about Falls Creek Healthcare Center if you want to pop over to their website while we take the break. It's fallscreekhealthcare.com. Not surprisingly, and we'll be back right after this.
Canada's only weekly radio show dedicated to the baby boomer lifestyle. This is Boomer Life on CIL 650. We're back. This is Boomer Life on CIL 650.
Welcome back to the program. We're talking women's health on this episode of Boomer Life with Dr. Roy Jackson from Falls Creek Healthcare Center. Dr. Jackson is a gynecologist. He's worked at several hospitals. He's on staff at Peace Arch Hospital and Delta Hospital in Ladner. He's also medical director of Southern Health Center at White Rock, and he is head of gynecological services at Falls Creek Surgical Center. And we've talked about an awful lot in this program, Dr. Jackson. You're being very patient with me. And on Boomer Life, we would be extremely remiss in our duties if we didn't talk about menopause. Since it's women's health issues on the program today, this is Boomer Life. Boomers are sort of 50 plus, and that just sort of dovetails quite nicely with the onset of menopause in most North American women, which happens roughly at the age 50, correct?
Correct. I mean, the average age is probably around 51.
Okay.
And I mean, that age of menopause is influenced by the age that a woman's mother might have been going through her menopause.
So it's hereditary
So
to an
it
extent.
has a hereditary component as well.
Interesting. So what is it?
So, I mean, it's some changes that a woman may go through at that stage of her life. And officially, we say that when a woman hasn't had a menstrual period for 1 year or longer, that she's officially in her menopause.
Right.
And I think that kind of academic definition really is really probably useless for a woman. What's most important to a woman is that if she's, the 50s, the new 40s, and the 60s are the new 50s.
Right.
Women are living longer, and mostly women are living longer than men.
Yes.
And during that period of time that they're in their 50s and onwards, they want to have quality of life. And it's all about quality of life. And I think for us as healthcare providers in the women's healthcare space, we have an obligation, and we have it's our privilege to be able to offer women that education, that knowledge, and the care to enable them to have that quality of life as they go through those years as they get older.
Now, as when it comes to menopause, and again, this is a guy talking here, not a gynecologist, so I've only been able to observe from distance, and of course you hear, and I heard a lot about hot flashes and all of this kind of stuff, but in my case, the women in my life who have gone through this have gone through it fairly smoothly. They've gracefully, one might almost say, but clearly this is not universal. So what surgical issues arise from time to time with women in the menopausal stage of their lives?
Right, and I think it's more a question, Sterling, of what kind of healthcare issues might a woman in her 50s or 60s, what she might encounter that's going to affect her ability to enjoy life and to have quality of life.
Okay.
And obviously, I mean, I work in White Rock and I work in the Lower Mainland, Vancouver, and, the women are living longer. One of the common problems that I see in my practice is a woman is having problems with bladder control.
Okay.
And it's starting to affect her quality of life. She might be a golfer, or she might enjoy cycling, or she might enjoy running, and she finds that now as a result of that, she's having problems with controlling her bladder. She might leak some urine. She might laugh and leak some urine. She might be at a cocktail party and someone tells a joke and she leaks some urine, and she might pee in her pants, so to speak. Well, the good part about it is that women don't need to put up with this.
Right.
And there's no reason a woman needs to put up with this. And, you just bear in mind that most of these women now have finished having menstrual periods.
Right.
And they no longer need to worry about wearing pads.
Sure.
And they've used pads or tampons for all these years.
Mm-hmm.
Suddenly they tell you they didn't realize they had to start wearing pads again because they're leaking urine.
Right. Well, and it's interesting you would use that specific example, because when I sat down with my wife over dinner last night in advance of this conversation, I said, well, I'm going to do something you've probably done a few times in your life, but I never have. I'm going to spend an hour with a gynecologist. And she said, well, lucky you. And I said, great, but what do I talk to him about? Not having any gynecological experience. And so she just, she rattled off a list and a half, I got to tell you. But one of the things that came out very early, she said her mom used to have this problem. It was, her words, leaking when you laugh. And that, it sounds, it's a real problem, and it's a real social inhibitor. It can be. How difficult a problem, Roy, is it to be, or is it to repair?
Well, again, I think it's important for us as gynecologists that we evaluate what's causing the problem.
Okay.
So when a woman has problems with bladder control, where she's leaking urine, which is really unexpected, we refer to that as incontinence, but there can be several causes of incontinence. But one of the commoner ones that we see a lot of, which often occurs in women who are active, is what we refer to as stress urinary incontinence, often abbreviated to SUI.
Okay.
Where they leak urine, as you said, when they laugh or when they cough or sneeze,
right,
or they jump on a trampoline.
Right.
And the good news about it is that, again, through innovation and advancement of technology, we're able to offer a solution to women which is minimally invasive. And so one of the treatments, once we've diagnosed the problem,
right,
one of the treatments is to put a tape under the neck of the bladder. The procedure is done generally from the vaginal side. It's a 15-minute procedure where we put a tape under the neck of the bladder so that when she does exercise or coughs or sneezes, she doesn't leak any urine.
Interesting. It's just that simple.
It's as simple as that. Again, most of these procedures, the success rate is at least 90%. And if done, if in the hands of a skilled surgeon, the likelihood of any complication is very small.
I'm surprised, though, that and again, it's my limited medical knowledge, glaringly obvious again, but I would have thought that for a urinary tract issue, that the woman would have gone to a urologist rather than a gynecologist like yourself. So there's some overlapping in skill sets there, isn't there?
Absolutely, and I think that it brings up a good point, and that is, because of the proximity of the anatomy In other words, if you think about the anatomy of what a gynecologist like myself does, working in the vaginal area,
Right.
and the anatomical proximity to the bladder,
Yes.
not only is there that anatomical proximity between what a gynecologist and a urologist does, but there is that professional collaboration.
Right.
And at a center like Falls Creek, we have the privilege again of working hand in hand and working side by side with a urologist. So for a woman who's suffering with bladder problems, she can either be seen by the gynecologist and or by the urologist. And often there will be that sharing of knowledge. And in today's environment where everything is about the internet and everything is open source, I think this again lends itself to what physicians have to strive to work together. It's not a question of, am I better than the urologist? Not at all.
Of course.
I want to work side by side with the urologist and fix the problem.
Sure.
You know, in British Columbia, we're fortunate in that no specialist is short of work. So that for me to work alongside the urologist at Falls Creek, surely we can provide a better solution.
Do you find, have you spoken with women who've come to see you, Dr. Jackson, with this particular incontinence issue, who have withdrawn? Essentially, they've sort of taken themselves out of the game because it is a social inhibitor. You don't want to be in a social situation where these little leaks occur, and so they sit on the sidelines. They become wallflowers, and after a certain point, I would think, get pretty darn frustrated.
Absolutely, and I mean you're 100% right, because if a woman's having to wear protective underwear, and if she's going to be involved in a situation where she might be at a party or she's socializing and she leaks urine to the point that it's embarrassing,
Yeah.
you're 100% right. She's going to withdraw from society.
Sure.
And so it's a testament to quality of life. And we can make such a difference in a woman's life by offering her some of these innovative ways to deal with their problems.
Now, as a complete aside, just before the break, with a vested interest in this question, does this incontinence issue present itself in males as well?
It does. Obviously, I don't see those males.
I
but
know that.
Yes.
I know, but I'm just curious.
Absolutely. So men do suffer with this as well.
Okay. Want to find out about prolapse when we get back, and my gosh, there's an awful lot more to talk about. Our guest is Dr. Roy Jackson from Falls Creek Healthcare Center. He is the head of gynecological services at Falls Creek, which, by the way, is at 555 West 8th Avenue here in Vancouver, and online at fallscreekhealthcare.com. We're back with more with Dr. Jackson right after this.
Celebrating the baby boomer lifestyle. This is Boomer Life on CIL 650. We're back. This is Boomer Life on CIL 650.
Welcome back to the program. Our guest in studio discussing women's health is Vancouver gynecologist Dr. Roy Jackson from Falls Creek Healthcare Center down there on West 8th Avenue in Vancouver. I'm Sterling Fox. Dr. Jackson, we were talking about menopause a little while ago, and you talked a little bit about what happens to a woman's body and the sorts of changes she goes through. And then we talked about incontinence issues and that sort of thing. But you've also talked earlier, and I wanted to come back to it because I'm just connecting the dots. I'm a little slow, but I finally connected the dots, and it's the post-menopausal bleeding. And as I understand menopause, to certainly the women I know, it marks the end of bleeding in their lives, to the extent where some of them celebrate rather vigorously. It's party time. That's over with. But if after all of that settles down, and bleeding continues, that would strike me as being rather serious right away. What does it tell you?
Well, as you say, it certainly is considered to be abnormal if a woman who's not had a period for a year or longer suddenly gets some bleeding.
Right.
And as I said to you earlier, I think it's crucial that the physician makes sure that we're not dealing with an important problem such as uterine cancer. Again, not all women who have bleeding that is postmenopausal is uterine cancer.
Right.
So I don't want our listeners to be scared, because fortunately the majority of women that come and see us who do have postmenopausal bleeding, it's not uterine cancer.
Okay.
But it's important to rule out uterine cancer. And the way we do that is with doing an ultrasound is helpful in addition to the examination, in addition to doing the hysteroscopy and to take a biopsy or do what's often referred to as a DNC or to sample the endometrium. to ensure that we're not dealing with uterine cancer. And again, the good news is that the majority of cases that we see, we're not talking about uterine cancer, and there are some other causes that contribute to a woman experiencing some bleeding at that unexpected time.
Right. Now, as we are in a discussion on women's health issues, and you have raised the issue of uterine cancer on a few occasions, we know that in terms of killers, breast cancer is still a rather prominent cancer in terms of as it affects women negatively and adversely. How prevalent is uterine cancer? Especially, we just know so much more about breast cancer.
Right, and I mean, uterine cancer is an important cancer. The good part about uterine cancer compared to other female cancers is that fortunately, because of that unexpected bleeding, we're able to diagnose uterine cancer early.
Right.
Unlike cancers such as ovarian cancers, where we're not as good as diagnosing them early. So the key thing with any cancer, whether it be a female cancer or male cancer, is early diagnosis.
Right.
And with uterine cancer, we're getting pretty good at picking it up early. So again, I think that's one advancement and one benefit in terms of uterine cancer. You mentioned menopause, and you mentioned women wanting to be young. I can't help but touch, Sterling, on the topic of estrogen.
Okay.
And estrogen could occupy 10 radio shows. But one area that I want to talk about in a woman who's menopausal is the value of estrogen in the vaginal area. So a lot of women who experience incontinence, a lot of women who experience a condition called pelvic organ prolapse, which we can talk about, a lot of those women, their tissues in the vaginal and bladder area is weaker. The tissues are fragile. I refer to them as fragile.
Okay.
The medical term that we call it is often atrophy or vaginal atrophy. I don't like that word atrophy because it implies that women are getting older.
Right.
No woman wants to get older. So if you substitute the word atrophy with the tissues are fragile, one of the ways to improve the quality of the tissue is to use vaginal estrogen. From the research that we've done, the studies that we've done, we're able to demonstrate that if a woman uses vaginal estrogen no more than twice a week, it's not going to be absorbed into her systemic circulation, and therefore she doesn't need to worry that it's going to be absorbed into the breasts, where there's the fear of obviously getting breast cancer from the vaginal estrogen. So for those of the listeners that are either using vaginal estrogen, to be reassured if they're using it twice a week, because it offers significant benefits in dealing with bladder problems and with dealing with vaginal health.
Okay. And I suppose, though, males and females, any boomer who experiences any unusual bleeding of any description should never take it lightly.
Correct. Exactly. And you need to definitely, our listeners need to see a physician if they encounter any problem like that.
What is prolapse? You were talking about prolapse a moment ago.
Yes, and I mean, a lot of the work that I do and a lot of the surgery that I do is geared towards women who suffer with a condition called prolapse, also referred to as pelvic organ prolapse.
Okay.
And essentially, the best way I describe it to patients is it's like getting a hernia of the pelvic floor. In a woman, the pelvic floor includes the bladder area, the cervix, the uterus, and the vaginal area, and it includes the bowels. That's the pelvic floor.
Okay.
So if a woman gets prolapse, she gets some sort of dropping down of one of the organs into the vaginal area. So that prolapse or hernia, unfortunately, is a common condition that we see it. Part of the reason it's so common is as a result of childbirth,
Okay.
as a result of the change in the quality of tissues, often because of the lack of estrogen. And another big causative factor is gravity. I often say to my patients, if they could walk around on their head, they probably wouldn't suffer with prolapse. So gravity plays a big role.
Well, it is interesting, and that's very, very kind way of sort of dodging the aging bullet too, because gravity does seem to affect us more and more as we begin to count more and more years, doesn't it?
Correct, exactly. And I mean, prolapse again is not going to kill people. So if a woman's suffering with prolapse, she could live till she's she's 100.
Right.
What again comes back to quality of life. And I think our listeners, our patients, are yearning to have that quality of life in their 60s, 70s, and 80s. And one of the conditions that is common, unfortunately, is prolapse. So I reassure my patients by telling them they can live till they're 100. But what can we do to improve their quality?
Right, and I think here's another thing that comes up on Boomer Life a lot, Dr. Jackson, and that's the whole question of, well, I'm too old for that sort of stuff. I've seen my better years now. I'm going to play the hand I've been dealt, and that's it. They're kind of surrendering, and there's a defeatist attitude going on, and more people are going, no, wait a second, life's too short. Let's get out there and have some fun. And so it's never too late to turn things around, is it?
It's definitely not too late. I mean, I have patients in their 90s and who come in to see me with prolapse, and we can offer them treatment. Some of it is medical treatment.
Right.
Not all of it is surgical treatment. For those patients that are in good health and maybe a little younger, we often offer them surgical treatment. And again, the benefit of Falls Creek is some of these treatments can be done and offered through Falls Creek as part of the multidisciplinary team.
Right. You mentioned estrogen. How important, without getting into the whole hormone replacement therapy thing, which again would take a show or three.
Right.
How important, though, for a woman going through the menopausal experience or even leaning to the other side of it, how important is it to sit down and have a discussion with her physician with respect to estrogen? Should I start taking some? Is my body now producing less to the point where I need to compensate for that? Or is Mother Nature going to handle this all by herself?
Absolutely. And I think, a good quality discussion with your physician, with a patient's physician, is crucial to analyzing their risk factors and analyzing if they would benefit from estrogen. Gone are the days where we routinely used to give every menopausal woman estrogen.
Exactly.
That's old hat. We
Right.
don't do that any longer.
Right.
We look at what are the symptoms, what are the problems that a woman's experiencing, and how can we personalize their treatment. So the future of healthcare, the future of women's healthcare, is going to be a very personalized approach, or what you probably hear about often now, which is personalized medicine.
Right, exactly. And so, again, the knowledge is power. You are impressed constantly. You're the guy they come to see, and yet you are impressed with the amount of information that many, many patients will bring to you. And yes, of course, as you've said, Dr. Google isn't always 100% spot on, but the fact is people are quite willing to do homework. And so they show up at your office, and they're ready for a good conversation, aren't they?
Absolutely. And for me personally, and this is my personal opinion, I really admire those patients that do their research and that are talking to people and getting knowledge. And some physicians are not as ready to accept internet research that patients are doing. I think it's fantastic, and I'm open-minded to that. And I think the question is to take what I refer to as internet information, and how do you convert internet information to knowledge, and then how do you convert that to wisdom?
Right.
And that's the role, and that's the relationship that the patient doctor can play, and the relationship that the patient healthcare provider can play in taking knowledge to wisdom.
How does a person get a hold of you? You animated, vigorous guy. You've been just a delight to speak with for an hour, and I know that you've already suggested that if a person wanted to see you, it's likely there would be a physician referral required. But how does a person get a hold of Dr. Roy Jackson? Do we call Falls Creek Healthcare Center and ask for your extension?
Yes, I work a lot of the time at Falls Creek Surgical Center as well as at Southern Health Center, so you can reach me through either of those organizations. I'm always welcome to see what I can do to help patients.
And you can learn more about Dr. Jackson on the website, too, at fallscreekhealthcare.com. A real pleasure to meet you. I mean, we met in the hallways when you were hosting the Empowering Women show here on CIL 650. A real pleasure to have an opportunity to sit down and really have a good go at your profession, and I've absolutely enjoyed this conversation enormously.
Perfect. Thank you very much, Sterling.
My pleasure. Great to see you, and please come back.
Thank you.
Okay. We'll see you next time right here on Boomer Life.